In contemporary times, more and more people are willing to go for cosmetic refractive surgeries as that will give a sense of independence and confidence for them. Modern day refractive procedures are not only effective but very safe too. Let's see by what all ways we can avoid glasses. When we think about avoiding glasses to a patient, LASIK is the first name which comes to our mind. Let's see whether LASIK is still relevant. We'll hear about it from Dr. Anita Jabbar, a senior cornea surgeon from iVision Eye Care Center, Chalakudi, and HOD of Cornea, Little Flower Hospital, Angamali. Over to Dr. Anita.
So, welcome to this post-lunch session. And I heard Kiran telling that all of the speakers are wearing spectacles and still they are talking about a spectacle-free world. But this is a suspense. So, let us hear what each one of us has to tell you. So, today I'll be speaking on a question that often comes up in every OPD and every public forum. Is LASIK still relevant? With newer procedures like SMILE and ICL gaining attention, it's important to understand where LASIK stands today, scientifically, practically, and in the patient perception. This is the legacy of LASIK. LASIK revolutionized the refractive surgery when it was introduced in the 1990s. More than 40 million procedures have been done worldwide with over 95% satisfaction. And it earned this trust because LASIK consistently delivered fast recovery, excellent accuracy, and predictable outcomes. It has truly laid the foundation for our spectacle-free world. So why LASIK became so popular? Patients loved LASIK because of how quickly it gives vision, functional vision, often within hours. And it was affordable, accessible, and produced stable results. So for nearly 2 decades, LASIK was the go-to procedure for most refractive errors. But today we have newer techniques like SMILE and ICL. But these are not replacements for LASIK. I would like to describe them as adjuncts. That is the procedures that fill the gaps where LASIK cannot be offered. For example, SMILE helps when we want a flapless, more biomechanically stable option. And the ICL works in thin corneas and very high myopes. Together, LASIK and SMILE and ICL allow us to personalize refractive correction for almost every corneal profile. So there will be no ideal LASIK candidates because of the thin corneas and the high powers and all, and they might be looking for flapless or more biostable options, and these gaps can be filled by SMILE or ICL. One major historical limitation of LASIK was the fear of ectasia. But modern screening has completely changed this. Today we have the pentacam, the tomography indices, the Bellin-Ambrosio display, epithelial mapping, corneal biomechanics with the Corvis ORA and all. The ectasia risk after LASIK had dropped dramatically. And today ectasia is rare but not zero, particularly in borderline cases, very young patients or subtle form frestic keratoconus. We should always keep this probability in mind. So remember, proper screening is versus technology matters. And also there is a dry eye risk because the LASIK does cause temporary nerve disruption because of the flap. So dryness is common for 3 to 6 months, but it is predictable and very manageable. So dryness with the preoperative MGD assessment with your omega-3 fatty acids or plugs or aggressive lubrication, most patients remain very comfortable. And in those with existing dry eye, those patients who come with you saying that I am having severe dry eye, then SMILE or PRK becomes the better choice for them. In very high myopia, removing more tissue can lead to mild regression over the years. It's uncommon, but it can happen beyond -8 or -9 diopters. Most cases can easily be corrected with enhancement or in borderline corneas, shifting them to ICL if there is the residual stromal bed is very thin. This is actually one of the biggest challenges today. Which one? The public perception of being LASIK being outdated. You must have heard that a lot of patients come and asking you, Doctor, LASIK is old. I heard Smile is newer and better. And a lot of this comes from social media marketing. But the reality is modern LASIK is safer and more advanced than ever. With wavefront guided, topography guided, and ray tracing platforms, LASIK today offers precision that was not possible 10 years before. So evidence also speaks. Multiple comparative studies, including the Reinstein's large 2023 work, shows that LASIK, SMILE, and ICL all have excellent outcomes. LASIK still remains the most predictable and most accurate for the majority of routine myopes. So in nutshell, at a glance, the evidence and outcomes shows that visual outcomes are equal to SMILE. Patient satisfaction is almost 90 to 95%. Enhancement rate is low, maybe 2 to 4%, and the safety is excellent with the femtosecond platform. Thus, LASIK remains the gateway procedure in the pursuit of spectacle freedom across age groups. Future trend is becoming even more exciting. AI-based screening is improving our ability to detect subtle patterns that even experienced clinicians may miss. So these AI-based screening is also very important. And techniques like LASIK Extra, that is combining LASIK with accelerated cross-linking, are helping to improve the biomechanical stability in particularly high myopes, younger patients, and borderline corneas. And this reduces the risk of regression and enhances the long-term stability. We now have the ability to map the corneal irregularities with extreme precision. Topo-guided LASIK is excellent for asymmetric astigmatism or decentered aberrations. Wavefront-guided LASIK helps reduce the higher-order aberrations and improves night vision quality. So the take-home message in our journey towards spectacle independence, LASIK remains a vital and time-tested choice. Thank you.
Now we know LASIK is still relevant provided the proper preoperative criteria is followed. Thank you, Doctor. Next we have Dr. Anil Radhakrishnan from Amada Institute of Medical Science. He is the HOD of Cornea and Refractive Surgery. He'll be talking about PRK and its increasing popularity in recent years. Over to Dr. Anil.
Thank you, Kala. Thank you, Jyoti, for the opportunity. The topic is PRK, the resurrection. I think the resurrection is mainly industry-driven. It's not because the PRK, we all prefer PRK nowadays. PRK has a safety and it's a great procedure. Now, if you want to do LASIK, there are hardly two companies which are making the blade LASIK, and everyone is switching to femtosecond LASIK. So that is why I believe PRK has become very popular. But the results are equally good. There is definitely, I think, great scientific evidence to say that PRK is as good as any other ablative laser procedure. So the credit goes to this man, Theo Seeler, who came up with PTK way back in 1983 and PRK in 1987. The advantage of PRK is that there are no flaps. So the flap-related complications you can forget about. So generally we do PRK in people in whom the pachymetry is on the lower side. The keratometry values are either flat or very steep, in whom there is a risk of flap-related complications in LASIK. Then if you have a recurrent erosion or epithelial basement membrane dystrophy, flap will definitely augment it. So in such cases, PRK would be desirable. And if you have a narrow fissure or deep orbit, or the patient is engaged in contact sports, definitely PRK would be better. So nowadays we see a lot of patients who have already undergone a refractive procedure in whom there may be an irregular cornea, post-PK, post-RK or post-LASIK. In such patients, PRK is preferred. So if you look at mechanically the strength of the cornea, Corvis has definitely shown that PRK is superior to any other flap-based procedure. So this is a short series which I had done some 10 years ago. At that time, ICL was not 10 years, 15 years ago in Trivandrum Chaitanya. At that time, we mainly high myopes we used to do PRK. And if you see the change in spherical equivalent, mean of minus 9.3, it came down to about 0.23. The results are pretty good. It was good then also. It is good nowadays also. The disadvantage with PRK is the pain that it causes. I think we are LASIK, the next day patient is very comfortable. PRK patients keep on crying for a few days. And there is always a risk of PRK haze. So why this PRK haze occurs? That is because of an epithelial injury which causes this interleukin release. And that actually drives an inflammation. And if the epithelium does not heal within a stipulated period of time, there is a tendency for haze formation. So some of these myofibroblasts will go to become fibroblasts and then that will produce the haze. So if the epithelium gets covered within a few days, then this will not happen. So this is not confined to PRK. This happens in C3R. This happens in corneal ulcer also. If the ulcer heals within a short period of time, the amount of scar you get would be very less. So other contributed things are the inflammatory milieu of the eye. You know, if you have blepharitis or dry eye, this will contribute to haze. So in general, Asians have a higher incidence of stromal haze. So I'll take a few findings from this preferred practice patterns of PRK surgery published in IGO in 2020 is still very relevant. So in the history, I'm not going into much into that. Only thing is, in people in contact sports, you have to be more careful. Then in the clinical examination, you have to pay attention more to the tear film. So if you look at the tear breakup time, meibomian gland disease and ocular surface disease index. If you have mild symptoms, give a lubricant and plan the surgery within a week. If you have moderate to severe symptoms, get down the blepharitis, use steroids, lubricants or doxycycline, get the inflammation on the surface very low, and then plan surgery, which will take usually about 3 to 4 weeks. Intraoperative things, there are two systems which were notorious for producing most PRK haze. It is not relevant nowadays. So what it depends, like people have debated whether the type of epithelial removal will contribute to the PRK haze. Whether you remove with alcohol or with amylase brush or you mechanically remove it, it is all the same. So this is a technique. Whenever I do PRK, I generally tend to use alcohol. So intraoperatively, it's a must that nowadays use 0.02% mitomycin. And actually, we should be doing it in almost all the cases. And previously, people never used to use it for if the amount of ablation was less than 50 microns. But nowadays, I think for Asians, it's better to use it in all the patients. So then you put in a BCL. Intraoperatively, there are people who use ketorolac. You dip the contact lens in ketorolac solution for some time, for a few hours, and then use it, and then the amount of postoperative pain can be reduced. That is possible. I don't generally do that. The main problem with the PRK patients is the postoperative pain. There are things like buprenorphine patches available. It is hardly 1,000 rupees. So this is very good in taking care of pain. I think the plastic surgery people and all routinely use it. Only problem is a small percentage of people get nausea after using buprenorphine. So you have to remove the patch, then wait for 1 day for the nausea to get relieved. But most people are very comfortable. Plastic surgeons, they put the buprenorphine patch 1 day before the procedure, and then the postoperative pain would be significantly less. There are diclofenac patches also, but it is not as effective. And I think nowadays it's not available. So I tend to use the usual tramadol plus paracetamol combination. In very fussy patients, we give ketorolac or diclofenac injection also. Post-operative care, it's very important. You have to make sure that the patient use steroids in the initial 8 to 12 weeks. That is very, very important. Avoid sunlight. UV exposure can augment PRK haze. If there is significant MGD, continue doxycycline for some more time, and vitamin C has a role in preventing haze. If you get a late onset haze, things are different. It's very difficult to treat. You can give topical steroids, and steroids and lubricants. But tacrolimus is recommended for about 6 weeks. Doxycycline you can use. Vitamin C also, antioxidant dose, 500 milligram 3 times a day you have to use for 3 months, and UV protection should be given for at least 3 months. So, but once you get a late haze, it's very difficult to treat it. Quite often you have to have a repeat procedure, taking care of all the preoperative parameters, getting the inflammatory milieu of the eye to the baseline and then do the procedure, and extremely be careful in the postoperative period also by giving good lubricants and steroids. And whenever, if you're using steroids, better to use, I think in routine we use the loteprednol, but in people in whom there is a haze or there is some more inflammation, you can give dexamethasone or prednisolone acetate. So I would like to conclude saying that PRK still holds a great position in institutions like LB Prasad. I think 2/3 of the procedures they do are PRK. I think about 1/3 to say 1/3 or 35% they do femto and other smile procedure. So if you pay attention to the surface and give good postoperative care, the results are as good as LASIK or any other procedure. Thank you so much.
Thank you, Dr. Anil, for those words of wisdom. Dr. Anil emphasized on the importance of surface ablation. Well, in our practice also, we do maximum surface ablation with excellent results. And I want to stress upon a point that it is not an outdated technique. One need not be afraid to advise. Thank you, Dr. Anil.
That is definitely there. When you are removing the epithelium, the risk of infection is there. So they have to instruct the patients. It's not like LASIK. You can't walk around from the next day. You have to be indoors. You have to keep the patient under good control for the 3-4 days till the epithelium heals.
And what is your mitomycin time?
For every micron, 1 second.
1 second.
Just like you people do. Yes, Punch. I usually put a drop nowadays without even without wetting the surface. Just put a drop and keep it like a pool there. Just 3 drops, so it will remain in that area. Then wash off of it. No. You should not go to the limbus. Yeah. So only limit yourself to the ablated area. Wherever the epithelium is gone, that area you limit it. So I generally put 1-2 drops, maximum 3 drops. It will make a drop and remain there. Then at the end of that, we'll wash it off. No. I just put the drop directly. Now, if you wet it, then it will go to the sides. So just like I think one of the people there, I think that Egyptian is there, who used to do a lot of PRK. That he had made the suggestion. So after that, I had been using it.
Anil, will you use cyclosporin to reduce the haze? Yes. Because Narayana Netralaya, they are promoting that 3 months of cyclosporin use will
before
reduce
pre-op?
Afterwards, after the procedure.
Okay. I have not used it. Maybe it
We
works.
are regularly
giving
for 2
cyclosporin?
months, yeah.
Okay. I don't know whether there's a relation between the cylindrical power. It's basically the amount of stromal ablation that you do. Okay. Cylinder, if you go beyond 4, definitely there will be some amount of residual cylinder. So even for LASIK or in fact any procedure up to 4, it gives good results. Beyond that, there you can expect some amount of residual power. That I'm not sure. But whatever studies I've looked into, there is no real difference between trans-PRK. One of the centers I go, I do trans-PRK also. I don't think there is any difference.
Yeah. Next talk is by Dr. Kala B. Thotam on lenticle-based procedures. Dr. Kala is a senior refractive surgeon from Chaitanya Hospital, Kochi. Over to Dr. Kala.
Thank you, Dr. Jyoti. As you all know, LASIK and PRK are established procedures, and we have been doing it for many years now, and it is still holds good for many patients. We cannot fix one procedure for one particular patient. Based on the patient parameters, we choose the technique that is suitable for the patient. Now, as you all know, the refractive surgery is advancing every year, or that is the most rapidly advancing field in ophthalmology. So, with the invention of femtosecond, we have lenticule-based procedures. We use femtosecond to create the flap for femtolasic, and flapless no ablation procedure we can do with lenticule-based procedure, or we call it CLEX, keratorefractive lenticule extraction. This term was coined in the year 2023. In this, we use the femtosecond laser to create the lenticule according to the patient refractive error, and we remove the lenticule through a small incision of 2 to 3 millimeter in size. So it is a no flap, no ablation, no blade technique. And so, as Dr. Anita was saying, we need a stable cornea. That is, always we are looking for better stable biomechanics of the cornea. So, lenticule, we are not disturbing the anterior stroma as well as the Bowman's layer. So, this gives, studies have shown that it gives better biomechanical stability. We have various platforms available for lenticule procedure. We have Silk from Elita, Smile and Smile Pro from Visomax 500 and 800, Clear from Zima, and Smart Sight from Schwint. Let us look into the various parameters each machine gives. Basically, the wavelength is almost same in all the four machines. The main difference is in pulse repetition rate, which is the maximum. The fastest laser is given by the Zima machine. Next comes the Elita, 10 megahertz. And we are trying to reduce the amount of energy per pulse from beginning, and now we have come down to 50 to 70 nanojoules, which is given by Elita. And next comes the Zima machine. And the laser cut time, initially it was around 30 seconds in Visomax 500, which has come down to 10 seconds. So the fastest laser is with Visomax 800. Then comes Elita, it is 16 seconds. And the patient interface varies in different machine. It is curved in Visomax 500, 800 and Atos, whereas it is flat with Zimmer and Elita. And the main problem in the beginning of the lenticule extraction procedures were the cyclotorsion compensation and the centering. So both are rectified now with the newer machines like Visomax 800, Zimmer, Atos as well as Elita. We can do cyclotorsion compensation, and post-docking centration also is possible in these machines. And the lenticule geometry, there is a side cut with Zeiss, Visomax, except for Atos and Zima. And the shape of the lenticule is planar convex in all the machines, except in Elita we have a biconvex lenticule. This picture is a geometry, shows the geometry of the lenticule. It has a anterior lenticule, this one here is the posterior lenticule surface. The upper part is the anterior lenticule, then the side cut. Just a small video. This, we have the Silk machine. So I'm using the Johnson's Elite machine, and we do the Silk. After the patient's parameters are entered, the laser is applied. And first step is identification of the plane. First the anterior plane, then goes to the posterior plane. This step is showing the separation of the anterior surface, then going to the posterior plane, and the posterior plane is separated. Elytra gives a biconvex lenticule, and the spot sizing is very close, so it gives a tissue bridge free lenticule, and so the separation is easier compared to other systems. We have to make sure the lenticule is complete once it is extracted. The main advantages of the lenticule procedure is we are not making a flap. There is no 300-degree flap size. So the nerve, corneal nerve transection is very less, and thereby the recovery also is faster, and the dryness also is very less. So no flap means there is no flap related complications also. And as I said, it gives a better biomechanical stability, and the less induced IOP rise intraoperatively, and studies have shown that the induced higher order abrasions are lesser with lenticules procedures. And factors like humidity and temperature won't affect the femtosecond laser application. There are some limitations too. The learning curve is steeper compared to LASIK and PRK, and there is in the initial cases we can have incomplete lenticule extraction, difficulty in finding the plane and separation. And the main drawback is the hyperopic treatment is not possible, and even pure astigmatism. We can correct compound myopic astigmatism, but pure astigmatism, as of now, the normogram is not there for the pure astigmatism. And of course, the cause factor is, it is more. But whatever said, it is definitely a pure, powerful addition to the armamentarium of refractive surgery. It gives very good results with high accuracy as well as excellent stability and less dry eye and better corneal biomechanics. Thank you.
Thank you, Kala, for that excellent talk about the newer techniques. And next, we will have the talk by our Chief Instructor, Dr. Jyoti Anup from Eye Vision Eye Hospitals, Thrissur. She is a senior phaco surgeon and phaco and refractive surgeon. And I congratulate her for this wonderful course. So the interesting hand-picked topics and covering the entire area of the spectacle-free world. And Dr. Jyoti will be talking about phakic lenses to correct the refractive errors. And her caption is phakic IOLs, not just an alternative. Over to you, dear.
Good evening all. My topic for today is phakic IOL, no longer just an alternative. I'll be talking on implantable contact lenses. Usually, they work like internal contact lenses, usually done for individuals more than 20 years and done in moderate to severe myopia. Ideally done who are not the candidates for LASIK or surface ablation, and it can correct astigmatism up to 6 diopter. And ICLs definitely give better visual clarity, better contrast and no glare compared to LASIK or surface ablation, and it is a reversible procedure. And the only demerit is it is an intraocular procedure, and so we have to do one eye at a time. And the first FDA approved US company is Star Surgical, which is there in the market from 2005. And there are Indian make phakic lenses also. The Star ICL is made up of collamer, and the Indian make phakic lenses are made with different material. They are hydrophilic acrylic material. Each company has got different names. Icryl by Biotech, refractive implantable lens by Apasami, and IPCL by K Group. And a thorough preoperative evaluation is mandatory as of any refractive surgery, along with the workup for other laser procedures. We have to measure the anterior chamber depth also. Anterior chamber depth should be more than 2.8 or more. Ideally, to begin with, it is better to select patient with ACD 3 or more. And a white to white measurement is mandatory, which has to be more than 10.8, and it has to be done by the surgeon itself. Also, you can measure the sulcus to sulcus and angle to angle measurement also. They are all measured by ASOCT or UBM, but you need high technical skill, and which is not always possible with the technician. And if you have a specular, it is ideal to measure the specular endothelial count also. And the loading of star ICLs, that needs some practice, and it is a bit cumbersome also. This is how you load the ICL. You have to inject visco and BSS, inspect the lens for any manufacturing defects, and with the cotton tip, they provide only one lens at a time, so you have to be careful while handling the lens. If you put it down, then that is it. And you have to pull with this special forceps, which is provided with the thing. You have to buy it, and ideally you have to pull the cartridge, then the lens will come forward. And here, this ICL loading needs some practice. You get dummy lenses to practice. And before making the corneal incision, it is ideal to load the lens. As what happened here, this lens got stuck with the foot plate got stuck with the haptic. And in such situation, you have to keep it open, and like you have to multiple times you have to open and close the forceps, and I am pulling it down, up and down, and somehow I got it with this. So it is always better to load the lens, keep it in the BSS to avoid drying, then you place the corneal incision. And implanting ICL is not that difficult for a person who does topical phaco, but care should be taken not to injure the anterior capsule while making entry. You have to have a very slow injection, and before the final push, you have to wait till the foot pedals, till the foot plates spreads out. And the tucking the foot plate is also another, that with the peculiar movement you have to put it in. And washing the visco after IOL implantation is a must. And while before implanting the ICL, the injecting visco, you have to be careful not to overinflate the AC. That will float the ICL and make your implantation under the iris difficult. So you have to don't overfill the AC with the visco. And here what happened, here I had a problem while injecting the ICL. I removed the cartridge before the trailing haptic was in. So these lenses are very thin. While injecting, any manipulations can damage the lens or torn the foot. Your foot plates can be torn. Luckily, I got it with this. And usually the implantation of the ICL take less than 5 minutes, but washing you have to take out all the entire visco, especially from the central pot. Otherwise, you may get a postoperative IOP hike. And this is a Indian made, this is a biotech ICL called ICRIL. There is no problem of loading. This loading is like any other IOLs. So beginner can always practice with an Indian ICL. Once you are comfortable implanting the ICLs, then you can shift to the other one. And toric ICL is also available. Usually you don't have to rotate it. Most of the time it is aligned in the 180 degree itself. And I insist the loading of ICL needs some practice, and washing all the visco is crucial. We do give post-operative acetazolamide for 2 days, as sometimes you may expect some IOP elevation post-operatively. And ideally you have to measure the volt. It should be, the ideal volt is 500. It should be between 250 and 700 microns. If it is a very low volt, the patient can get cataract. And if it is too anterior, patient may develop glaucoma or even corneal damage. Thank you.
Thank you, Dr. Jyoti, for that very lucid presentation. And you have touched upon everything in ICL. And ICL surgery appears simple, but you have the preoperative assessment, as she was telling, and the postoperative yearly OCT, yearly vaulting measurements, and assessment of cataracts. Everything will be different. So next talk is by Dr. Anup Chiret, Senior Phaco Surgeon and Managing Director of iVision Eye Hospitals, Thrissur. His talk is on refractive lens exchange, utilizing the multifocal armory. Over to you, Dr. Anup.
Ideally, I think we could have just have had a roundtable discussion because there is only that many people here. So refractive lens exchange, just to complete the armamentarium of correcting refractive errors, is nothing but removing the clear lens to correct these refractive errors. So the benefits is as for any other refractive procedure, but the additional thing maybe as a selling point, you can tell that you won't get cataract in the future. So that is a patient for them, it may be something impressive. So exclusion criteria, again, all those which are there applies for any refractive surgery. In addition, those patients with risk factors for retinal detachment, especially if you are planning to do in myopes, those patients should not be taken. And those with ocular inflammatory diseases, because obviously it's an intraocular procedure, you may aggravate those problems. Since it's a precision surgery, because the patient doesn't have any cataract, already has good vision. So if you want to do surgery on this patient, their expectations will definitely be high. So definitely, even if you are not able to correct the refractive error fully, at least you should not introduce any complication because of your some certain wrong preoperative evaluations or measurements. So your biometry should be on the dot. Always better if you have optical biometer, but even a ultrasonic biometer with immersion, if it is done properly, is good enough. But definitely the formulas that you use should be the advanced newer formulas like the Barrett's Universal 2 or the Kane formula. Both are very easily available, so that your calculation of the lens power should be on the dot. And then if you have these higher and anterior segment evaluating machines like where you can measure the angle alpha and kappa. So especially if you are doing in a presbyopic patient, if you are doing, so there, this is important. These angles are important. If they are more than 0.5, those patients one should not be taking up. And these machines will also give you the higher order aberrations which the patients may have. So if they have significant higher order aberrations, those patients also at least we should not take up for a presbyopic IOL correction. So this can be done, RLE can be done in myopia, hyperopia, presbyopia and astigmatism along with all these combinations. In myopia, of course, there is always a risk of retinal detachment, especially going for those with higher ranges of myopia, more than 6 diopters. The incidence of retinal detachment can be in the range from 2 to 8%, depending on various studies they have shown. And in young patients, the risk is more. And of course, if you have intraocular complications like a posterior capsular rupture, or if you have to do a YAG capsulotomy post-operatively, this risk will be multiplied. It can, complications in myopia, especially risk of RD, can be reduced to some extent by doing prophylactic barrage laser if you have any degenerations, or and post-operative also you have to really follow up properly with indirect ophthalmoscopy. But all in all, I always try to avoid, personally I don't do refractive lens exchange in those with myopes. Only if they have cataract, only I touch them, because there is no point unnecessarily subjecting them to this risk of. And I have had a case where the patient did get an RD after a few months of time. So once you have such a complication, then you generally learn from that. But in hyperopia, it's a different ball game altogether. Here, refractive lens exchange is definitely much safer, and the results also definitely much better than any other corneal refractive procedure. So here you can very safely go in with this. And the additional advantage is that many of these patients have a shallow anterior chamber. They are predisposed to closed angle glaucoma. So if you do a refractive lens exchange, the angle opens up, and you, in addition to the refractive correction, there is an additional advantage that you are preventing angle closure glaucoma. The only problems in hyperopia is that these are intraoperative problems. Because of the shallow anterior chamber, definitely the procedure is more difficult, because there is very less space wherein you have to maneuver. And because of the same thing, the chance of endothelial damage is also more. And the chance of intraoperative hard eye is more in those with hyperopia, probably because of either uveal effusion or aqueous misdirection. So this was a young lady with around 31 years of age. She had +7 diopters of refractive error. So after surgery, before surgery, her uncorrected vision was just finger counting. So after surgery, she got almost 612, which was the maximum correction possible with refraction, and she was really thrilled. I had to use a +39 diopter lens. Here, of course, I don't think presbyopia correcting lenses are available in these sort of powers. But then if you do for both eyes, and if you make either go for emmetropy, or if you make one eye slightly myopic, -0.5, they are more than happy. And then there is no fixed rule that you have to use only premium lenses for refractive lens exchange, provided your patient selection is good. Like this patient had almost 2.75 diopter, +2.75 diopter. So even with the enhanced monofocal, the patient was very happy. But of course, you have to convince them that they have to do both eyes, at least in a small gap of time. Not that one eye after now and one after 6 months or so, because then by that time they will never be happy, because they have to use high power in one eye. So we always tell them that if at all you go for surgery, you better plan it like this, where you have a time to do both eyes. We always do one eye and then the other eye after 5 days. So we tell them beforehand. And then similarly, even simple, very normal lenses, normal packages also can be done with this. And you just give them a monovision, and in the dominant eye you make them emmetropic, and the non-dominant you give them around 0.5 to 0.75 of a myopic this thing, and they are really happy. And refractive lens exchange in presbyopia, now we have got a huge range of lenses available. All this, and in addition to this, the EDOF lenses also. But here, of course, you have to tell them about, if you are using a diffractive sort of lenses, you have to tell them about these problems, because before this, they are using glasses, but they don't have any of these issues. But now you make them free of glasses, and then you gift them some additional problems which they didn't have beforehand. So they may not be really happy. So here you really have to tell them about this. They can get these issues, and then only you take them up for surgery. So this was EDOF diffractive lens. So here again, like I said, since it's a precision lens, even a small diopter, this patient had half a diopter of astigmatism along with the spherical power. So here, in such cases, you mark the steep axis if it is in the accessible regions. Because if it is not in the accessible, like superonasal or inferotemporal, you can't do anything about it. That's better not to select such cases. But here, since it was accessible, and you do put your incision on the steep meridian, you can again chop off around 0.25 to 0.3 diopter from the 0.5. So the patient has almost emmetropia. And in the end of it, you have to see that the IOL is well centered. Your Purkinje's reflexes you should see under coaxial illumination, and they should be within the central most ring. So you are sure that your IOL is well centered on the visual axis. Now the non-diffractive EDOFs have come. They are, I personally have found them in my experience. I've been using them now for some time, and the patients are really happy because these problems with glare, halos, and starburst, those are significantly less. I was always I personally am very afraid of these problems because you imagine, I am also very finicky about my sight. A little bit, even a 0.25 cylinder changes, I get disturbed. So that I can just empathize with these sort of patients because can't imagine having to live with to see a point light with a full halo around it, as though you're looking through a fog. So I never was a very big fan of all these diffractive lenses, but now once this non-diffractive have come, I've been using them quite a few, and they are happy in the sense they may not get N6 for near, but then they don't have the problems of halos and glare. And so most of them are really quite happy. So this is also probably one of the very effective ways of correcting pre-existing refractive errors. And definitely, if you select the patient well, you can give them good correction and make them happy. Thank you.
Thank you, sir. As sir told, RL is effective, giving excellent results in selected and motivated patients. I have one question. Do you counsel? Do you recommend refractive lens exchange in your regular patients?
For only those who say that they want to get rid of glasses, and then those people who have say +3 for distance or plus more than +2. I suggest to them that you don't have much any cataract. Even if they have just cortical, I tell them you have minimal cataract, but the advantage is that you will get excellent, you will be very happy post-operatively. Your vision without glasses will be good, and even reading also you will be able to manage somewhat. Even if you give a enhanced monofocal, you will definitely be good, is the assurance I give them. So it is up to them. If they choose, yes, we do.
Hyperopic with early cataract patients are the ideal patients. Thank you.
So if the axial length is going beyond with the normal IOL formulas, I have seen you showing the Kane formula. Which other formulas you prefer for a very high myopia, very high long axial length?
We generally, I mostly use the Kane, and with that we have got good results only. We don't use the Barrett's or anything. And even the Holiday 2 and all, we are not really using them much. So with this, I've told the optometrist to make every month, I tell them to do a study of all these abnormal powered lenses. And they will give in the end of the month whether there are any surprises. So with Kane, somehow I've never had any surprises. I don't know.
Online calculator you
Yeah.
And you do monovision for this, or if they don't
Yeah.
use spectacles?
I always try to do a monovision for them. Yeah, if they are using a monofocal lens.
Yeah, Dr. Anup, a very nice presentation. What's your preferred lens for a like hyperope? Will you prefer VT, pure C, or
Nowadays, I am preferring pure C or IHANS or pure C.
Okay.
Both of these lenses, even for those many surgeons, doctors, and all, they're coming putting these lenses, and they are happy actually. Even active surgeons and all.
Pure C is the like if you want good intermediate vision.
Yeah.
And yeah, for surgeons and all, pure C is the one that you.
Yeah, even IHANS, they are good because IHANS also they say up to almost 40 or this thing they can get. So one general surgeon, he came post-op after 2-3 months. I asked them how's things. He said, I'm very happy, comfortable. Without glasses, I am operating because they operate at this distance.
Yeah.
So they seem to be happy with that.
Optimum intermediate vision.
Clarion. The Clarion I have not used much actually, so I'm not in a position. That you say that also gives good results.
Yeah, I am comparing a study on Swiss form and Clarion. And the intermediate vision is almost like I have not done the analysis, but almost the same. Good intermediate vision.
Okay, yeah.
Clarion is also.
Clarion
monofocals.
Okay. I have not used much of that.
I just want to make a comment regarding the myopes coming for this refractive lens exchange. So I had a patient, somewhat VIP, he He came to me because he was a high myop. I was not at all willing to operate on him. So he went to US, and US 2 places he went, and they suggested this. He wanted, I think, some intermediate vision glass. This one. Then I operated, and then he is actually able to read N6, but he is very unhappy because in myope, I think generally we only some part of the light is going into the near vision. So in a myope, if they remove the glasses, everything is going to near vision. We can never match that. So that is a very important thing. So myope, you had to be extremely careful regarding RLE.
But only the low to medium myopes, no? Those with say -5 and 6 and all?
This guy had -8, but I think he had a habit of lifting up and reading.
Reading.
So that's, I think I told him not to get operated. Then he wanted, like after getting opinion from US, then he got into trouble.
Their natural near vision.
That you cannot give.
Before touching, you have to ask them whether, like, how is their regular routine practice. Whether they lift up the glass, then don't touch it. If they read with glasses, then okay.
And the one other I wanted to ask, how like you all Indian, the smart phobe and even the oral lab has come out with. So what is your opinion with these sort of lenses? Kiran, you use smart phobe, you know? Indian ones. Swiss phobe.
Oral lab, that one is, I think, Oral lab EV or something.
Yeah. Now
that is quite good, I think.
Good.
I use very few.
Hours.
The problem with iHands is that it sometimes gives spectacular results in certain group of patients, and sometimes it just behaves like a
monofocal. Yeah.
So we're not really sure which one. So we don't actually counsel them that this is going to give you a. We kind of use this as simply a premium form of monofocal. Both Clarion and iHands. iHands seems to slightly give better results. Again, these are simply anecdotal experiences. One thing I wanted to ask you, anybody can answer this. What are the IOL formulas you use for post-LASIK eyes, post-PRK eyes? And would they, what about what happens when these clear smile patients undergo cataract surgery later? Would that, is there any impact on the formulas? Anything different?
I use Barrett True-K for the IOL Master 700.
So if smile and anything changed any of that?
Smile, I don't have much experience, but post-LASIK, post-RK, very predictable results and no hyperopic. They won't go for the hyperopic shift.
Shamas also, we use Shamas. That also gives quite on the dot results. Yeah.
No, I tend to use Barrett True-K. That is one thing. Then I calculate the K also, like that formula is there. No?
Yeah. Mechanically you calculate.
Mechanically we can calculate the K. Then as a third measure, you can take the pentacam or the topography machine, the central 2 millimeter area. And 3 values if you take the K, and then you get a proper result, because only thing that can go wrong is the K. So with the K we can calculate. So I use in such cases I definitely take 3 methods. The ACR is online calculator, you put the K as this and then to get the result. I use that Vivinex Impress also. It is what I found is it is as good as iHands.
Yes. Yeah. And their injectors are super actually.
Yeah, superb.
Yeah. Even the iHands and their injectors, you have to really stretch the cornea and put inside. But this like goes smoothly. Yeah.
So anyone has experience with that Rainer EMV lens?
No, not right.
Kiran? No.
So, no, iHands, and you said you don't counsel them. How do you differentiate between Technis and iHands? Like the package will be different, no?
Look, of course, I think a lot of depends on most of the patients I operate are patients whom I have been following up for glaucoma for many years. And generally, and I've also noticed this, like the practices such that practically nobody will want to do a trifocal and spend that much money. But nobody, I mean, in the list I'll find hardly any patient who will be using an Indian, that kind of lens. So everybody is very happy to spend 40,000-45,000. So that kind of difference between Technis and iHands practically never matters.
Okay.
So we kind of tell you this is the lens that I kind of prefer. I actually kind of write eye hand / clarion. That is usually taken. That's just the nature of practice, I think.
Okay, okay.
So that difference of say 3 or 5,000
They
does not
won't.
seem to matter
Yeah.
for the kind of patients we generally see.
Uh,
But we also don't have those patients who will put in a panoptics, multiple times. That also doesn't happen. And that applies to our mixed procedures also. We can't convince patients to put in a 1.5 lakh stent. But if you charge only 35,000 for a KDB, you have enough number of patients. Every OT you can do 2-3 cases. So that extra 35,000 people are okay to spend. But for 1 lakh, 1 plus, that is too much. That is too much.
the 1 lakh, I think, is the barrier, mental.
And but then you have practitioners, for example, in Netradama and all, Dr. Sri Ganesh and all, who will put any number of eye stents, not a problem, because that is the level of practice they have. So if somebody has a basic glaucoma and cataract, it's like femto plus eye stent. That is only when this surgeon will do. Otherwise, it will be left to some other, junior surgeon. One patient actually told me this, so that's how I know.
I have one question to Dr. Anil. Like, have you come across with any PRK haze, and how did you manage?
No, I have seen a few PRK hazes even after using mitomycin. Just give steroids and the tacrolimus, and usually it will subside.
They can have some hyperopic.
Yeah, that will be there. So we'll tell them that this refractor is not going to be there later, but quite often it disappears. I think generally 6 months is the average time. That I don't know, that LEDAR machine and Summit laser is notorious for producing PRK haze. But among the newer machines, I think there is nothing which you can really.
Common.
Yeah,
It's
very, very
so
rare.
far I've seen.
Okay. I don't know about that.
We certainly used to get more referrals for IOP hikes when the PRKs used to be more and much less now with femtolasic and IOP spikes. With PRK, you put in so much of steroids. So I remember get a lot of referrals post PRK, IOP hike and IOP hike. Nowadays, with the femtolasic and clear being done by our refractive surgeon, that number seem to be quite less. But clear also, both clear and femtolasic, that cause more keratocyte activation. They give steroids for a longer period. Yeah, but 4 weeks to 6 weeks. The percentage of, maybe the
very
strength
less.
of steroids, it seems to be less. It could be a simply anecdotal feeling that I have. But PRK, we used to get a lot more. Okay. In fact, PRK traps have happened. Okay.
And to Dr. Anita, which is the best microkeratome or the microkeratome of your choice? Which one?
Microkeratome I am used to the superior hinge, like the nasal, the cutting of the nerves. Moria.
Why don't anybody use this presbyopic classic, presbyond or something? Is that not done these days? Or?
Presbyond is done for the presbyopic corrections, and it is predictable results. Maybe that monovision also they are using, and micro monovision.
Yeah, because all of you are.
No, I have only done to the surprise of refractive surgeons. I think I have done only one presbyond. That was 48-year-old lady. I mean, she had very good result. But the thing is, presbyond, it's usually beyond 50 we cannot do. So by the time you get presbyopia, you'll be 42, 43. Then the time that in which you can do presbyond is limited. But it's not totally micromonovision, but one is dominant eye is corrected for the distance, and other eye you will be having maybe 0.25, 0.7, some refractive error, but your near vision will be perfect.
And the neuroadaptation also.
Yeah,
takes
that is
care.
there. Even our Shaji Hussain has undergone presbyond.
But it is a progressive, presbyopia is a
my doubt, this thing is after you do press buyout, then of course after say 55 you get a cataract or something. Will the calculation be a problem?
It has to be a problem. I think it will
Because
be a problem.
you cannot use the standard formula, no? That guy, the one who invented, this press buyout, his talk was in IARSI. So he said that that's not an issue. You can use the normal formulas, you get good results. But then that's what he's saying. We don't know.
Anybody using that pilocarpine high strength eye drops for the early presbyopia?
I just
I
gave
have
for
tried
2
on my
patients.
eyes. There is no. Maybe I am.
No, but I think it is for early presbyops. It is like around 39 to 43, 45 something you can give. I just gave for 2 patients.
I don't know, but there is one thing anecdotally. Uh, the pilocarpine drops were introduced in the US some time back. Okay, so what have happened is there are anecdotal case reports of increased incidence of retinal detachment.
That is OTC there, but they must have used.
Yeah, it's the same pilocarpine for presbyopia. Yeah, but these are anecdotal case reports, but obviously that is something we need to keep in mind. Even if they are anecdotal reports, the risk of retinal detachment versus spectacle free, that really there is no sense
Why?
at all. Yeah, that is true. But I am saying these are purely anecdotal reports, but it is like this. You start this pilocarpine drops, and 2 months later a retinal detachment, and similar such 2 or 3 case reports have been published so far. Of course they could be completely unrelated, but with pilocarpine having its role of contracting the peripheral zonules and things, we obviously want to keep that in.
Thank you. Let us wind the session. It's time up.